Assignment 1, clinical anesthesia. Name is Sarah Waters, and I am presenting a case study. Just gonna read off my paper here. She is a 25-year-old female coming in for a chole, 65 kilos. So we're gonna meet her in holding and just do our pre-op chat. So we're gonna ask her about medical history, surgical history, any concern with MH in the family. She doesn't mention anything significant, any medications, just takes birth control, no medical history that is concerning, surgical history, nothing. When was her last meal? She hasn't eaten since the night before. Any history of drugs or alcohol, mentions no drugs, does drink from time to time, nothing that's concerning. Does she have any allergies? We'll do a quick physical airway assessment kind of thing. Do I see anything that make me concerned or that I should plan otherwise for, which doesn't seem to be the case. So we'll get our room prep, make sure our suction and circuit and backup supplies are available, and then I will prep airway drugs. So we'll get the patient into the room, get her hooked up to monitors, our basic monitors to start, blood pressure, SAT, ECG. We'll get an IV started. Just 20 gauge is probably more than adequate for what we're doing. Hook it up to a 1 liter of ringers. Let that go wide open. We'll start open, just make it up for deficits. For the 4-2-1 rule overnight, you get closer to the 600 to 800 mils in. You might want to slow it down because she's probably met her requirements. And we're not putting a Foley in because it's a shorter case. So at this point, we can probably get her off to sleep. So we're going to pre-oxygenate with 100% for a couple of minutes, or get her to take some nice big breaths. And then once we're satisfied there, we'll start with our drug combo for induction, which will be 20 micrograms of sufentanil. We'll give 1.5 mics per kilo of propofol, so maybe roughly like 90 or so. We'll give 50 of rock, and we will watch to make sure she's asleep before we give the rock, and then we'll give it 90 seconds before we attempt our intubation. Put a number 7 tube in using a 3 MAC, watching for the teeth. Insert, confirm with CO2, hook up to our anesthetic machine, get her on the vent with appropriate settings. We can tape that tube, tape her eyes. We're gonna turn on some SIVO at about 2%. Watch our end tidal SIVO, we can see as it titrates up to what we need. So she's now asleep. That is gonna be our maintenance of 2% for the whole case. We're gonna put a upper body bear hugger on her, and they can commence the surgery. Sorry about that. And I should have no major concerns for maintenance for her. We'll just maintain with some ringers. We'll maintain with our target of about 2 to 2.2% of SIVO just for maintenance. If she feels like our vitals indicate that she's had a little bit more pain and the sufentanil's wearing off, we can give her 5 to 10 more for maintenance. I would also give her some 4 milligrams of ondansetron to make up for post-op nausea and vomiting. Make sure we give that before we extubate so that it has time to take effect before we go. So at this point, our case is commenced. We're going to extubate, so we will turn our flows way up and turn our SIVO off, let it wash out. Once she has made appropriate motions and that end tidal SIVO has gone down and the patient is breathing on their own and making appropriate motions and such, we can extubate her and put her on any oxygen mask, make sure her vitals are appropriate, and she can go to post-op. Just for post-op concerns, I would go with Tylenol first for pain management because it's not something we would have a ton of lingering pain. If we felt like she was still having excessive pain, you can have surgery reassess, or we can maybe give her just a small sniff of like 0.2 of Dilaudid. And that about covers it.